everyone, and welcome back to another insightful episode of MedSynapse podcast series. I'm your host, Hetvisha, and today we're diving into a transformative era in cancer care with a topic evolving paradigms in thoracic oncology, from surgery to systematic precision care. And joining us is someone who truly is shaping this evolution, Dr. Manikandan Venkatasubramaniyan, a highly skilled surgical oncologist with expertise in robotic and minimally invasive thoracic oncology. Trained at global centers like Shanghai Pulmonary Hospital, he's among the few in India proficient in uniportal VATVs, with over 100 robotic surgeries and multiple national awards to his credit. So, Doctor, it is an absolute pleasure to have you with me today.
Thank you. I would like to.
So, Doctor, to begin with, could you outline how thoracic oncology has evolved over the past decade from being primarily surgical to now multidisciplinary precision-driven field?
Actually, when you see the evolution of thoracic surgeries, it started from very morbid open surgeries previously, like 2 or 3 decades back. There is no other option for, even though there is advent of laparoscopic surgery, which gained momentum in the abdomen surgeries and pelvic surgeries, but thorax was one less traveled by. So many people do not venture into the laparoscopic thing in thorax when you see for 2-3 decades before. But many people are ready to venture into the abdomen through laparoscopy, but not into thorax. Because thorax is one less traveled by, and the complications will not let you sleep in the night if there is some complications. And all the complications happening in thorax are very morbid complications. So many people thought that doing a minimally invasive in thorax with both the lungs expanded, there will be no space, there will be space constraint, and all those things will happen. So, but when you see the recent past, when you operate with that, the magnification is very high. Like you get a 4x magnification laparoscopy, up to 10x magnification robotic. So on a stable camera in robotics and 3D vision, that has helped you a lot to identify what kind of structures you are dealing with. And you are able to see the minute structure in a very detailed manner in case of minimally invasive surgeries, even though the learning curve is there for this minimally invasive access. But it is not a challenging thing. Anybody can go and learn and start doing it. The only thing in India is many people are not oriented towards the thoracic surgeries. Many people are oriented towards the GA surgeries, pelvic surgeries and all other surgeries. But when you see the number of thoracic surgeons in India, when you count, it is very less compared to GA surgeons. So that is the issue here. It's not about the patients. We have enough patient load. Only thing difference between the Southeast Asian countries like China and other people from India is that we have enough patient load, but they are not getting diagnosed at the initial stage. The whatever surgeries I'm telling, like robotic and laparoscopic surgeries in thorax and uniportal and all those things, is well done when the patient is having an early stage disease with the learning curve of Indians. If you go to China, even the advanced diseases, they do under laparoscopic and robotic because the learning curve is completely different. The volume is completely different. But in India, if it is early to moderate stage, you can still go ahead with laparoscopic and robotic surgeries. And the volume is there in India. The only thing we are falling back is that we don't have a strong screening programs for lung cancers like we have for breast and cervix and all those things. These screening programs has to be strengthened. And just screening is nothing. It's a very easy screening. Like you do a HRCT test, one CT scan test is enough. That itself is a screening for any lung-induced pathologies. So these kind of surgeries, this kind of screening will increase the patient load for us and thereby increasing the outcomes for the patients who has the early stage disease. This robotic precision and uniportal VATs. One more advantage is that patient has a lesser pain. For example, when you do a thoracotomy, you have to cut the bones, cut the muscles and all those things. Patient will have long-lasting pain. And post-operatively, patient will have difficulty in breathing, and followed which there will be a consolidation of the lung. He will not be able to do spirometry, and all issues will happen with the patient when you do open thoracotomy. But when you do a minimally invasive thoracotomy, where we are not attracting the muscles, we are not cutting the muscles, we are not cutting the bones, but we do the same surgery or better surgery due to magnification effect. We do better surgery in robotic and laparoscopic. Nodal yield is better. We can see multiple tissues. We can preserve the tissues which is required. So in this kind of minimally invasive era, what happens is next day patient sits in the bed with no pain at all. And then he does the spirometry, and then he starts walking the post-op day 1, and he gets discharged in 4-5 days. But when you do a thoracotomy, patient will get discharged in like almost 10-15 days with a lot of pain, morbidity and all those things. So this is recent advances is like this robotics and VATS, and that too uniportal VATS. In previously multiportal VATS was there, but now it has been refined to uniportal VATS, where all the kind of surgeries can be done, even a sleeve resection, everything can be done using robotic and sleeve. And one more advancements in this thoracic surgery science is that advent of a staplers. We get different staplers for vessels, we get different staplers for lung and bronchus and other tissues, everything. The staplers has made our job easy actually. We need not to worry about the bleeding because of suturing and knotting, all those things. So you fire a stapler, everything is secured and your surgery is safe and patient goes home very quickly. So this recent advances in the form of robotics as well as this uniportal VATS with good magnification, good skill and good outcome for the patients is the trending one now.
Yeah, I think that's an excellent overview and actually really highlights how dynamics in this field has become, and it has changed over the decade also. So let's just build on the dynamic part. So how with systematic and targeted therapies taking center stage, how do you see the role of surgery changing in the management of lung and thoracic malignancies today?
So just like advancements in surgery, there is advancements in medical field too, like medical oncology and radiation oncology. They are very advanced. Like nowadays, there is nothing called not curable. Everything you have a solution. Like for example, even if a stage 4 lung cancer, if you ask me, if it is a mutation positive, EGFR positive, they live longer. There are studies which say they live for 60 months. Can you believe like stage 4 lung cancer, like 20-30 years back, stage 4 lung cancer never crosses 9 months or 6 months or so. They never touch a year. But there are studies who says that in the median survival of stage 4 lung cancer, EGFR positive lung cancer with advent of this targeted therapies and immunotherapies, they are living up to 36 to 40 months, even 16 months. 16 months is equal to 5 years of life. So it's all very advancements is happening in immunotherapy level and targeted therapy level. And each and every lung tissue we do a biopsy. We send it for a mutation analysis. So now the treatment is being targeted to the particular gene which gets mutated. So each and every mutated EGFR, KRAS, or multiple mutation level, P53 and all those things. So advent of immunotherapy, and we don't give a gross chemotherapy like which acts on all cells. We give a targeted therapy, immunotherapy, which specifically act on that specific mutations for that lung cancer. And the results are excellent and fabulous. You see the 10 centimeter mass coming down to 2 centimeters and patient is living more. And because of this advent, even the inoperable stages of lung cancer are being made operable by these kind of immunotherapies and targeted therapies. So even if patient comes with a locally advanced disease, we give the immunotherapy and chemotherapy, targeted therapy pre-op, and then we reduce or shrink the stage of the tumor, and then we are amenable to surgery. We are making them to come to the surgical table and thereby giving the best form of cure for the patient. So this locally advanced diseases are better dealt with this chemotherapy, immunotherapy. And if you see like the number of publications or number of research works happening among the cancer society, the large number of researches are happening in 2 of the cancers. One is the breast and second one is the lung. I would say these both cancers, the amount of researches which are happening on each and every molecule and every cancer cell, it's like amazing. You cannot even believe it. Every month there is a new drug. Every year there is a new form of treatment is coming and evolving. So one should be very dynamic in knowing what is the current state of treatment. You cannot say the same treatment which is said 5 years back because that is now obsolete. You cannot do it that. So now it's a dynamic growth of science. We see like every month a new drug, new trials are happening, new drugs are coming, new targeted therapies, new immunotherapies. So one as a doctor, one has to be on tiptoe to know the latest trends of what is happening in this lung and breast cancers. So there is nothing called not treatable or not curable. So everything we have a solution, everything there is a drug to treat it. This chemotherapy, immunotherapy has made actually surgery easy, or it has downstaging the disease and thereby making the patient who are not operable to become operable. So these are excellent advancements in science. like every drug which they do, most of them gets FDA approval, which can be used all over globe. So it is the immense progress. Even after whatever I'm talking now can become obsolete after 5-10 years. So that's what the new technology might come. Even a robot can sit and operate the patient. So it's all evolving techniques, and the artificial intelligence is taking the upper hand now slowly. So the artificial intelligence, what way is helping us to do segmentectomies in lung? How can we plan the segmentectomies? It automatically tells which segment, how much is the blood supply, any variation is there or not, everything. It is evolving like you cannot keep it pace with that of kind of development which is happening. So this immunotherapy, chemotherapy, and other targeted therapies, even radiation, everything is very immense growth, and so probably there will be no patient left out with no treatment.
Yeah, I think that's very insightful, and the shift is also truly redefining the care, and especially every disease has its treatment, so it's really incredible to know. So now, doctor, now let's talk about precision that you were also talking about. So now, precision oncology has revolutionized lung cancer care. So how is molecular profiling like EGFR, ALK, KRAS, reshaped treatment algorithms, and even your surgical decision making?
So actually, by doing this targeted approach to any lung tumor, we are actually de-escalating the treatment. Like instead of giving a full dose of chemo for a lung cancer, if we are able to identify some mutations in the lung tissue, like EGFR, KRAS, and other gene mutations, we are avoiding chemo. There are studies that which avoids chemo and give only the targeted therapy for that patient. The patient is advanced disease. So by doing this, what happens is that one thing is patient side effect profile is coming down. They don't want to tolerate the toxic chemo anymore. Second is that the responses are better. Only the cancer targeted cells are being killed compared to normal cells, which patient doesn't want it because they want it for their life. So that is why this targeted therapy is now in the guidelines. It is mandatory. If you are diagnosing adenocarcinoma of lung, they are saying that don't start any treatment before doing a molecular profiling. So even if there is no targeted mutation, we go for an NGS, next generation sequence, for entire gene analysis. So we found out any mutations. If there is a drug available for the particular mutations, we add that. So now it's not like somebody wants to do it is doing it. Is in the guidelines. You have to do it before you start your any form of treatment. That's what the guideline says. Before starting any form of treatment, kindly go ahead and do the molecular profiling of that tumor and find out what is happening within the tumor cells, which gene gets mutated, any actionable target mutation is there or not, if the drugs is available or there or not. If it is available, go for that. That is what they say. The multiple trials has been published for it. Each and every drug we have a trial. So it is not like for immunotherapy we have a lot of trials like checkmate and all those things. For targeted therapy we have a lot of trials. So these trials are telling that the overall survival and disease-free survival has a very significant improvement in using these kind of treatments. Side effect profiles are less. So it is not someone wanted to do molecular profile, some doesn't want to do molecular. It's not like that. It has to be there. It is the guideline. You have to follow it for you to have the better outcome. So molecular profiling will stay, and it also will start evolving. So these kind of molecular, this precision surgeries like minimally invasive with advent of immuno and chemo targeted therapies, these three combined can give the best results for lung cancer, which was once thought as taboo. If you see, if lung cancer, you detected with lung cancer, they feel it like a taboo, anyhow is going to die. There are multiple movies in Tollywood or Bollywood, everything. Patients once diagnosed with the cancer, they die. It's not like that. Nowadays, you see the number of patients who got cured of cancer is more compared to number of patients succumb to the cancer. So now the table has tilted the side. So now previously before 20-30 years, number of patients dying of cancer is more. But now number of patients living of cancer, we have just started the break even and we will succeed in it.
Yeah, actually, very well mentioned that even if you see last decade also, the number of patients and the taboo that was in the mindset of patients if they were diagnosed with cancer was very different like it is now. So now, doctor, screening is another game changer that I would like your thoughts on. So with low dose CT screening gaining recognition, so what impact do you foresee on stage migration and curative treatment potential for lung cancers?
So that's what I said at the beginning. Also, I said we lack in that. Actually, the one thing which we have to improve is that our lung screening. So lung screening is not even a blood test. It's very easy for the patient. No prick, no pain. You just go. It is a high resolution CT scan, which is not painful. It takes hardly 2 minutes for a CT machine to scan your lung. Nowadays, of advance of technologies, there's ultra high resolution CT and all those things, which can even go up to 0.5 mm, 0.25 mm, 0.3 mm cuts, which can even detect even a 0.5 mm to less than 0.5 mm nodules in the lung. So previously 1 mm nodule is required for CT scan to pick it up, but now even 0.5 mm can be picked up. So it is at the cancer budding stage, we say, like small nodules, anything to be done, we can do it then and there. So obviously this kind of screening has to improve, but the penetration of this knowledge of lung cancer screening into the second tier and third tier cities are very lacking. Even in first tier cities, many people doesn't know. Many people smoke. They have a lot of air pollution. See, in Delhi, they say that if by living in Delhi, you smoke 90 cigarettes per day, which is amazing. Just by living there, you need not to smoke. Over and above, we smoke also. So what is it going? I don't know. Just by living in Delhi, you smoke 19 cigarettes per day. Even an infant, starting from infant till 80 or 90 years old, geriatric patients, just by living, you are smoking 19 cigarettes, and over and above, you are smoking also. So what will happen to your lung? You think about that. So the penetration of this, there is some guidelines for screening, like the Interstates, the Prevention Services Task Force has given us some guidelines. They say that more than 50 years of having smoking index of more than 30, these patients who has lived smoking within 15 years, the last 15 years, they have to undergo lung screening in the form of HRCT test. And any medical checkup, you can see that medical checkup plan, like for example, 3 health checkup or something medical plan. In all those plans, this HRCT has to be included for patients who are smokers and greater than 40 years of age, is what I feel. It has to meet as guidelines. For example, by default, you will get all your blood sugar done, your hemoglobin done, everything. Those packages will be there in the test if you go for a pre-medical test or something, master health checkup or something. But nobody will include a HRCT test. But this has to change. Then only you can identify the disease early and you can have the better cure rates. Actually, one sad part is that even though the advancement of science is there, like almost 70 to 75,000 cases of lung cancer are being detected in our country per year. Almost 70 to 75,000 people are detected with lung cancer. But only almost 66,000 patients die of that. You see, only almost less than 9,000, 10,000 people live to say the story to others. So this lung cancer screening has to, because the more and more advanced stages you go, the more and more overall survival will dip. So this has to penetrate and it has to be included in the master health checkup by default, because it just takes no contrast, nothing. Just you go into the CT scan room, 2 minutes done. That's all. This is very easy test, very cheap test. There is not even no need to bother about kidney function test and all those things for giving contrast and all those things. So it's very easy test. So anybody who is a smoker, more than 40 years of age with good smoking history, and by living in Delhi itself, you are qualified for this. By living in Delhi, you are qualified for master health checkup to do a lung cancer. It's like that. So one has to penetrate that into different levels of our community, and everyone should get awareness. See, breast cancer awareness, yes, it has penetrated to 3rd level due to government support and many initiatives and all those things. But lung cancer awareness is still not penetrated to that extent. We have to do that.
Yeah, I think awareness will increase the chances of early detection, and then that's how the mortality rate will decrease as well. That's right, you mentioned. So now, doctor, finally, while guidelines and technologies are advancing very quickly, so what are the real-world barriers, especially in India or similar settings, to implementing precision thoracic oncology very widely?
In drawback for us is the loss of lack of knowledge among the public about lung cancer and what to do. That is one thing. We cannot blame them also. It is the government's part to do that. Their role to create awareness. Like government was creating awareness for HIV very effectively in India, that by reducing the transmission rates and getting some knowledge. Even a layman knows that by using condom you can prevent HIV. So it has to penetrate to that level. Even an uneducated person will know he has to use condom to prevent HIV. It has to penetrate to that level. The government initiative has to be to that level. Then only we can take. Other thing is the cost factor. When you come for a more precision surgery of uniportal VATS and robotics, it costs you. As of now, it costs you. But future it might come cheaper. Like many robots are being installed all over India. Many robots are being installed, and when the facilities are available more, then automatically the rates will come down. Slowly, it will become affordable to a normal individual also, like open surgeries. So we hope for that, and government has to take this initiatives of creating awareness into the public. Like it has created successfully for polio, it is successfully for HIV, it has created successfully for leprosy, and these three things are under control in India as of now. So very rarely we see HIV positive patients nowadays because of awareness and all those things. So that is what we need. Need of our is to penetrate the thing into the third tier city. Even a layman should know what he is to do, what not to do. It's like that. So long steps has to be taken, and the affordability issues has to be taken care of. It will automatically be taken care of because advance in technology automatically. See, there was once a time that we paid 300 rupees for 1 GB data, like almost 10-15 years when I was doing the college thing. Now you get free 2.5 GB per day. So that will the advancement in science will bring the cost cheaper.
True. Yeah, true. With so many advancements coming in, it will obviously reduce the cost also effectively. That's rightly mentioned. So, Doctor, thank you for sharing your insights, and this has been truly an enriching conversation. And thank you for sharing your insights on the evolving paradigms of thoracic oncology, Doctor. And to our listeners, thank you for tuning into this episode of MedSynapse podcast series. And remember, if you're a healthcare professional who is eager to delve deeper into medical topics or have questions, do not hesitate to join us on the MedSynapse platform. MedSynapse platform is not just a resource, it's actually a dynamic space where you can connect with your medical peers, participate in meaningful discussions, and contribute to the ongoing evolution of healthcare. So until next time, stay curious, stay inspired, and we'll see you in the next episode.